Unmute yourself, please, Linda.
Good morning, everyone. Thank you all for joining us today. As Casey said, my name is Linda Pond, and I am the president of the board of the Oregon Nurses Association. In just a few moments, you will have an opportunity to hear from two of my colleagues, Matt Calzia and Natasha Swartz, who will present a series of ambitious and crucial new policies that we hope will spark conversation and discussion. These policy recommendations reflect the kind of bold actions that we believe must be adopted if Oregon is to move beyond the current crisis facing the nursing profession. Over the past few weeks and months, ONA has been asked by reporters, legislators, our valued members, and our communities to answer difficult questions about the impact of the COVID-19 pandemic on Oregon's nursing workforce and our healthcare system. These questions have focused, quite rightly, on the impact COVID surges have had on nurse morale, on their ability to deliver the highest quality care to patients, and most recently, what we think about the governor's vaccine mandate and the quick approaching October 18th vaccine deadline. We have endured to be thoughtful and balanced in our answers and in our policies, all the while maintaining our deep commitment to our members and the nursing profession. This has been a very, very difficult time for all nurses in Oregon. We know that the vast majority of nurses in this state are vaccinated. We know that upwards of 90% of ONA members are vaccinated. We also know, for example, that as many as 96% of nurses at OHSU are vaccinated. However, we know that a small amount of nurses across the state have made the decision to not get vaccinated, and those nurses will likely be terminated from their jobs. We know that losing even a single nurse from the bedside will result in greater strain on our healthcare system, and we have urged hospitals and our lawmakers to do everything they can to keep nurses working for the benefit of the patients. Today, we are here to talk about not what happens on October 18th, but what we must do to finally and seriously address our historic and catastrophic nurse staffing crisis. ONA believes we must focus attention on two key issue areas: retention of nursing staff and addressing the challenges in our nursing workforce pipeline. After Matt and Natasha deliver their remarks, we will make ourselves available to you for questions. Please note, if you have a question, please type it into the chat box along with your name and your media outlet. We will call upon as many of you as we can, and if we aren't able to get to your question, our communications team will follow up with you afterwards. We will also be providing a short 2-page overview of our policy proposals for your information and are eager to speak with any member of the press who wants to explore these important proposals in more details. We will begin today on the issue of nurse retention, and I'm pleased to introduce Matt Calzia, RN, one of Oregon's nurse practice consultants. Matt?
Thank you, Linda. Good morning. My name is Matt Calzia, and I'm a nurse practice consultant at the Oregon Nurses Association and a practicing bedside nurse. I recently returned back to ONA after taking a month off to help at the bedside in the ICU at Sacred Heart Medical Center in Springfield. As a direct care nurse, I want to reinforce something Linda said. For patients and frontline nurses, Oregon's healthcare system has been broken for a long time. Our pleas for changes to make the system patient-centered have been ignored by hospital executives for decades. To move beyond the current crisis, if we are to not only improve our healthcare system, but literally save it, Oregon must take bold, decisive, and immediate action. We don't have all the answers, but we are exploring a range of options, and we strongly encourage our elected officials, hospital administrators, coordinated care insurance organizations, and public sector agencies to accept our challenge to think big and bold. The future of Oregon's healthcare system depends on this. ONA is asking for greater attention to be paid to two key areas: nurse retention and the nursing workforce pipeline. Let's first talk about retention. ONA is calling on hospitals to pause in their plans to rapidly return to a high productivity business as usual model of operations. As nurses, We understand the impacts of the delays in care that have been caused by this pandemic, but we also must acknowledge there are not enough nurses, and the nurses we have are very fatigued, and there is no short-term fix to what is a global problem. We have seen consequences of the failure to consider nurse and caregiver staff availability during the spring and summer when hospitals rapidly moved to operate at maximum capacity, trying to run at 110% every day, every shift. OHSU provides an example of what not to do in response to the ongoing crisis. 85% of the nurses at OHSU have indicated that they are unable to use vacation time or take a mental health day because there are not enough nurses. 92% of OHSU nurses are experiencing mental exhaustion. 86% report experiencing fatigue, burnout, and moral distress. And perhaps the most concerning number, 60% of OHSU nurses indicate they are considering leaving the profession entirely. And yet last week, OHSU sent an email to nursing staff indicating they intend to keep this up. They said, and I quote, "To staff available beds, there may be times when we need to have RN staff to flex patient assignments beyond what is a typical patient load in acute and critical care areas." And a couple of days later, they sent another cruel and callous email stating, "We want to reinforce messaging delivered last week. We will also employ strategies, increasing RN staff patient assignments, charge nurses taking patient assignments to meet the needs of the organization, not the needs of the patients and not the needs of their nursing workforce." So before this surge is even over, and before nurses have had the chance to take a day off or get any kind of respite, OHSU is already asking for nurses to go above and beyond yet again. This return to business as usual model wore down the workforce before the Delta surge even hit and did nothing to address the strain, the stress, and the burnout caused by the beginning of the pandemic. This must not be allowed to happen again. Hospitals and communities must better manage how, when, and where care is delivered. Second, ONA is calling on hospitals to honor legally required meal and rest breaks for nurses and immediately end all buddy break system practices. Many nurses work 12-hour shifts and never get a rest break. If a nurse wants a rest break, they must leave all of their patients under the care of another nurse, essentially doubling that nurse's workload. This is a significant cause of nurse fatigue, and it negatively impacts the patient experience. Hospitals must immediately end the buddy break system, and they must commit to ensuring rest breaks and meal breaks as required by the Oregon Bureau of Labor and Industry and in compliance with the Oregon Hospital Nurse Staffing Law. Third, ONA is calling upon hospitals to address the unsustainable practice of relying on traveling nurses. Hospitals across Oregon are dangerously dependent upon very expensive traveling nurses. We know that across the country, the demand for traveling nurses has gone up by 280%. And on any given day, there are more than 40,000 travel nurse positions available in this country. In Oregon, we are seeing that up to 30% of the nursing staff in some hospitals are travelers. In other hospitals, turnover is so high that the majority of a unit might be composed of traveling nurses during some shifts. And traveling nurses are a crucial part of the way Oregon is responding to the staffing crisis. And we should all be very grateful for their presence here. But they are not the answer to Oregon's long-term staffing crisis. Because of the large financial incentives travel nurses receive, nurses who have worked in the local hospital for years are leaving to take travel assignments, meaning that there are fewer nurses in the hospital, resulting in the need for more travelers and perpetuating a cycle created by healthcare executives. All hospital systems must begin planning for how we can wean ourselves off traveling nurses and turn those resources toward retention pay, incentives for existing staff, and improving the nursing work environment. Fourth, ONA is calling on hospitals and the Oregon legislature to support new investments in nurses' mental health. First, there must be an investment in destigmatizing the suffering nurses are experiencing, acknowledging this is harm caused by a failed system, not a failure or a weakness of the individual nurse. Second, health systems must provide mental health services necessary to help frontline caregivers manage the impacts the pandemic and the staffing crisis are having on them. That includes direct financial support to staff to cover costs of mental health services like private counseling. Third, ONA is calling for the Oregon legislature to support an expansion of the Oregon Wellness Program to include provision of mental health services for nurses. The Oregon Wellness Program is a statewide system operated by the Foundation of Medical Excellence that is funded by a combination of public and private sources. ONA wants legislative support for funding of approximately $1.8 million biannually to support this expansion. Finally, we are calling upon the governor and the Oregon Health Authority to create a commission to engage in a systemic review of Oregon's overall healthcare system staffing. This commission would have a specific focus on assessing Oregon's hospital staffing model and would develop recommendations on how best to strengthen staffing across all aspects of healthcare delivery: hospitals, home health, clinics, schools, long-term care, and other clinical settings. We're also asking this commission to explore how to strengthen Oregon's nurse staffing law, including more robust enforcement mechanisms. Years of neglect by healthcare system executives has resulted in a near collapse of our system. We can't allow these healthcare systems to rush back to the status quo that got us into this situation. We need a patient-centered healthcare system. And for that to happen, we need to have a robust and healthy nursing workforce. With that, I'm pleased to introduce Natasha Schwartz, a member of the ONA Board of Directors and a nurse at OHSU, who will discuss ONA's recommendations on how to address the nursing workforce pipeline. Thank you.
Thank you, Matt. Good morning. My name is Natasha Schwartz, and I'm a proud member of the Oregon Nurses Association Board of Directors and a registered nurse at OHSU. Prior to joining the ONA board, I served as the Oregon Student Nurses Association representative to ONA, and nursing education and workforce issues are very important to me. The current nursing crisis the state of Oregon is facing, as Matt and Linda have both said, has been decades in the making. As we see some small number of nurses potentially leaving the profession due to their decision to decline vaccination, we are also concerned that burnout will lead to an even larger number of nurses leaving the bedside. And in Oregon, we will not be able to educate a large enough number of nurses to replace them. Given the stress and strain registered nurses are experiencing today, it is also important to understand that many potential nurses look at the profession with suspicion. Why would a young person choose to enter nursing when the job is so difficult? Nursing education and workforce development, or what we call the nursing pipeline, is the second area where ONA is calling for bold and decisive action. First, ONA is seeking immediate action on one of the root causes of our staffing issues, a shortage of nurse faculty. What is the major cause of the nurse faculty shortage? Pay. Faculty salaries must more closely mirror clinical salaries. Given the fact that nursing faculty can make significantly more in a clinical setting, we must address wage disparities to retain qualified educators. One direct way to address pay disparities is for the Oregon legislature to advance and pass legislation like the state of Washington did in 2019. Washington State's House Bill 2158, the Workforce Education Investment Act, appropriated nearly $375 million to address student needs. It also designated a portion of those funds for increasing nurse educator salaries and high demand program faculty salaries at community and technical colleges. Next, we are asking for healthcare systems and nursing degree programs to actively seek new partnerships, specifically to address faculty salaries. A hospital or healthcare system can partner with a nursing school by providing direct salary payments to support increasing a nursing faculty member's salary. Those nursing faculty could serve as preceptors in the hospitals where nursing students would do their clinical placements. ONA is calling on the Oregon legislature to consider a wide range of other initiatives, including tax credits and student loan forgiveness grants for nursing faculty, helping to create incentives for talented educators to stay teaching. Second, ONA is calling upon nursing programs to explore innovative ways to address clinical placement challenges for nursing students. These clinical placements are a key part of a student nurse's education, and without an expansion of opportunities for clinical placements, nursing programs are forced to limit registrations. This might include simulation-based learning, something that the Oregon State Board of Nursing supports to meet up to 49% of clinical education requirements for licensure. Innovative thinking around the challenge of clinical placement has become even more crucial during the COVID-19 pandemic, and more innovation is necessary to create capacities for nursing students in the future. Third, given that costs for nursing programs are often cited by potential nursing students, and particularly students from underrepresented communities, as a significant barrier to entry, ONA is calling on our state's philanthropic community to dramatically increase the number and scale of scholarships for nursing students. The Oregon Nurses Foundation has already provided some scholarship opportunities with the focus on students in rural areas and students of color, but larger trusts and foundations in Oregon can and should be focused on providing crucial scholarships for students entering nursing school. In particular, we are calling upon the creation of new scholarships targeted specifically at students of color, bilingual students, and students from rural areas, all of which are underrepresented in Oregon's nursing workforce. Finally, ONA is calling for the Oregon legislature to investigate the creation of an Oregon Nurse Corps that would provide student loan forgiveness for nursing students who agree to complete 4 years of work in areas of the state with the most serious nursing shortages, including rural areas and community-based organizations that address needs of underserved and marginalized populations, in critical access hospitals, and in critical need units. The details of such an Oregon Nurse Corps would need much greater research, but this is an example of the kind of bold action we are seeking. Fixing the nursing pipeline will require partnerships, collaboration, and innovative thinking. These are just a few possible ways forward. ONA thinks about this crisis in a variety of ways, but one important question for Oregonians to ask is this: if we as a state are not able to retain experienced nurses in the profession, how are we going to replace them? Failing to address the nursing pipeline simply ensures an even greater crisis in our future. Thank you. Linda Pond will now wrap up and take your questions.
Thank you, Natasha. Hold on, I'm having a technical difficulty. I apologize, everybody. It seems to be the morning for that. If members of the press here today have questions, please begin posting your name and media outlet in the chat. ONA staff will call on you in a moment, and we would ask you to all remain muted until you are called upon to ask your question. If there's a single takeaway from our discussion today, I hope it is this: the nurse staffing crisis didn't start with COVID-19 or with vaccine mandates. It was created and compounded by hospital executives who have consistently chosen to put profit ahead of patients. It's why we're here today and why we're facing a generational challenge to provide high quality, affordable health care to people who need it. Nurses alone can't solve the nursing crisis because we didn't create it. This is a systemic crisis brought on by corporate healthcare executives who failed to address problems until they became too big to easily solve, starting with our nurse staffing crisis. Next year, there will be more registered nurse jobs in America than in any other profession, but we'll still need 1.1 million new nurses over the next decade to replace the nurses that we're losing and providing the care our patients need. Right now in Oregon, Providence alone has 2,000 open caregiver positions. Many of these are RN positions. You don't wake up one morning and realize you need 2,000 more healthcare workers. Staffing shortages happen over time, not overnight. Nurses have been demanding hospitals address short staffing for years, and hospital executives have ignored us. Because it's cheaper to run lean, it's cheaper to stretch the people and resources thin. It's cheaper to hire one nurse to do the job of 2 to 3 nurses. That is to hire one nurse than it is to hire one nurse to do the job right. When hospitals are short-staffed, you and your family members pay the price. You pay it with 12-hour ER visits. You pay it with more hospital injuries and infections. Your grandmother pays it when she has to go back to chemo because her cancer surgery was postponed due to a lack of staff. We all pay it with taxes to cover the cost of hundreds of traveling nurses and 1,500 National Guard members who are called upon to plug the gaps. And finally, you pay it with a higher risk of death when you enter the hospital. Decades of research have shown that nurse staffing is one of the most effective, affordable ways to keep patients healthy and get you home safely. Studies show adding one nurse to a hospital's team can reduce your chances of dying by 16%. Simply put, safe staff nursing saves lives. Nurses are calling for stakeholders, frontline workers, and hospital executives to step up and reimagine how and why we provide healthcare. We need to put patients and staff ahead of profits before it's too late and there's no one left to care for us. Now, we will take your questions.
All right, and thank you, everyone. We have a handful of questions, so I'll call on each reporter as they are given an opportunity. So our first question comes from Kellee from KATU.
Good morning. Thank you so much for taking our questions. I have sort of 2 questions. The first one, so before I ask the second one, if it's okay, Matt and Natasha, can you kind of, I feel like the thing missing from this is walk us through kind of your personal experience so far this year, or well, almost 2 years now. Just tell us what your experience is like on the day-to-day, and then if it's okay, I will ask my other question after that.
I can jump in first. So I started at ONA about 2 years ago, a little bit before the pandemic started. And I returned for the surge. I was getting really distressing texts from my colleagues who are at the bedside in the ICU, and felt that I could be a service to them just to help as like a helping hands in the ICU. And what I saw, one of the most distressing things was seeing the despair on the nurses' faces and the fatigue. And it's more profound than I've ever seen that. And having that kind of break and then getting back into the ICU and seeing what my colleagues are going through is tough. And then I had an experience with a new graduate nurse who had a patient who was declining outside of the ICU. And it was their first day off of their new graduate residency. And what I saw in that nurse's face was just real despair. And the patient was stabilized, everything was okay. And afterward, we were debriefing the situation. And there was this despair and this look in the nurse's eyes, because that's all you can see is eyes because of all the PPE, that like, what did I do? And I think Natasha touched on that. How are we going to get folks into this nurse workforce and then keep them in if that's their situation? And that was really disheartening. And then what we see, from the patient perspective of seeing, almost all unvaccinated patients, and the ones who are vaccinated were very vulnerable with things like, organ transplants, so they're immunosuppressed. Seeing what that does to patients, and I've had a decade of critical care experience, and to see the whole ICU filled with the same diagnosis, that never happens. In flu season, we might have 5 or 6 sick flu patients in the ICU, not 30 of the same diagnosis. That's like a mass casualty event. And then they stay for a long time and they are extremely critically ill. And that takes a real toll. And I think what the numbers miss when we get the report of how many infections, how many hospitalizations, and how many deaths, is we don't necessarily make that connection that 2 weeks ago when we saw hospitalizations going up and then we see the deaths, those are the people that admitted 2 weeks ago. And that's why our bed capacity started to get better after a few weeks, was because the people who were admitted died. They didn't get better. And that takes a toll. And you can see it between that and just the fatigue. You can see that on all of the nurses at the bedside. It's very disheartening. It's scary, to be frank.
And thank you, Matt. And I would ask Kellee, if you want to ask your second question. We do only have about a little less than 10 minutes to answer questions right now, so we want to make sure we get to the next ones and make sure everybody has opportunities to ask their questions. So thank you.
Okay, my quick question then is, there's conversations going around right now about requiring nurses to get the vaccine, or they could lose their nursing license altogether. I mean, is that going to exacerbate the problem you guys are already talking about? Do you have a take on that?
Well, I can answer that. The Oregon State Board of Nursing is planning on meeting on October 13th to discuss proposed rule changes. ONA doesn't really have a comment at this time, but we're looking carefully at any decisions that will be made by OSBN. Until then, we encourage members of the press and the public to direct your questions about this and your concerns to OSBN. And that's, since we don't really know where it's going, that's as much as we can say right now.
All right, and now we have another question coming, this one from Christine at KGW.
Hi, thanks for your time. Just a quick question about getting our brains around how many nurses we're talking about who may be thinking about potentially leaving the profession. I know, Matt, you had mentioned like 60% of OHSU nurses indicating they're considering leaving the profession entirely, but like, I don't know if anybody can speak statewide to the number, like, I mean, I know the percentage at OHSU, but the overall number of nurses, if you have any indication, who may be leaving the profession because of so much burnout that you've been talking about.
I cannot quantify that number. But the 60% is consistent. Not, the American Nurses, or the American Association of Critical Care Nurses, recently came up with the same number, and that was like a national survey, and they came up with around 60% looking to leave the profession. So at OHSU, I think they have around 3,000 nurses, so 60% of that. And then, if you could look at ONA, has around 15,000 members, and we can, looking at the national data from other organizations who've surveyed nurses and looking at our own, we can assume that 60% is a pretty consistent number. So the math, I don't have be able to quantify it by how many nurses exactly.
Thank you.
All right, next call on Dawn from the Northwest Labor Press.
Hi, thank you. Yeah, I actually have a number of questions, but I'll try and narrow it down to a couple. And I also just want to say, you said something about there only being 10 minutes left, and we all waited for 20 minutes to get the call started, so I'm not sure why we would need to end, and I hope you'll let everybody ask the questions that they want to ask. I guess I'm really appreciate you bringing this up. This is a long-term issue of the nursing staffing shortage, and it's gotten much more acute, obviously, during the pandemic. It seems like it's almost everything you're talking about is in a way the same problem. You've got overwork that's resulting from understaffing. You've got, traveling nurses being employed as a very expensive fix to the problem of retaining and recruiting nurses. And so I think it seems like you sort of made the case, and I think this is probably the case, that the underlying issue is underpay, that they're not offering enough pay, they're trying to run too skimpily. And so I wanted to know, what is the typical pay range for an RN and ONA? And then also, when we talk about overwork, what are the typical hours that are being worked by ONA members? And then lastly, and I'll put these in the chat, lastly, why can't individual nurses or ONA set a limit on hours and refuse to work over that? I'm thinking, if the nurse is on the verge of leaving, wouldn't it be better just for them to refuse overwork rather than leaving altogether?
I can go ahead and talk about the overworked portion. So usually, at least in my setting, we work 3 12-hour shifts. But the last, year and a half, everyone has been picking up a lot more hours, working between, 100, 120 hours in 2 weeks. Yes, we could say, no, we're not coming into work. But as nurses, we have this obligation to take care of patients. We don't want to see our coworkers suffering the way we would if we were short-staffed. So we feel this need to go into work when we're already so exhausted, because we know that if we don't go in, they're going to be short, several nurses on a unit that shift, and we cannot deal with those consequences. And that's because we went into nursing because we want to care for patients and we want the best possible outcomes. And we know that that is not possible when people are working short-staffed. So yes, we could say, no, we're not going into work, but nurses aren't going to appear out of thin air, and our coworkers would just be short-staffed and suffering even more.
And can you share what the typical pay is, and if that is a key issue of, am I right to identify that? It seems like there's a labor market problem. In theory, if you can't find people, then you raise the pay and you find people. But this has been going on for a while. So why is that not happening? And what is the typical pay right now?
What I can say about that is that all of our nurses in Oregon are, in most of our facilities in Oregon, the nurses work under negotiated contracts with the employers. Nurses in ONA happen to be extremely well paid. I'm not up on the exact hourly rate these days, but we are, I want to say, like the 5th best place state in the country for nurses to work in because of our working pay and benefits that most facilities here offer. So in Oregon, it's not just about the pay. It's more about the working conditions. It's about the fact that hospitals have made it a point over the years to reduce staff at the bedside to protect their bottom line. And that's just a fact. Nurses have, like Natasha said, sucked it up, basically, shift after shift after shift. And when you are a registered nurse in the state of Oregon, you work at OHSU, Peace Health down here in Eugene, Providence, your telephone blows up with text messages daily. As a labor and delivery nurse, I would get 6, 7, 8, 9, 10 calls a day for help at the bedside. That's not because nurses don't want to work here because we're not well paid. It's because hospitals don't want to hire the nurses to cover the shifts. So it's a different dichotomy than what you're seeing down in the Deep South. But even in the Deep South, those nurses are woefully underpaid. They are the most poorly paid nurses in the country, and there is minimal incentive other than the desire to care for human beings that are in times of crisis in their life to inspire people to be a nurse in the Deep South. And the same is true on the East Coast in a lot of places, and even in rural Oregon. it's nurses' passion that we do this job. It's not so much about the money. It's about the fact that we care for humanity, and we have all come into this as a calling, not because we want to get rich off of being a nurse. I hope that helps answer your question.
Thank you.
All right, thank you. We have the next reporter to ask questions is Suzanne from the Bend Bulletin.
Yes, hi. Thank you very much for putting this together. My question is, do you have any sense of how many nurses are not going to be vaccinated from your membership of 15,000, and what their reasoning is about why they don't want to get vaccinated?
What I can say to the answer to that is that within ONA, more than 9 out of 10 nurses are already fully vaccinated. We know that there's a small number of nurses that may continue to decide to not vaccinate or file an exemption. And if they choose not to get vaccinated and do not submit a valid exemption request, hospitals and healthcare companies can decide to find a reasonable accommodation for them. Or removing them from their normal work schedule, putting them in non-clinical settings where they can, provide support, but they're not coming in patient contact. And a lot of hospitals are saying they're not willing to do that. They're just going to terminate these nurses. It's a very small amount in answer to your question, given that, the majority, like we said early on in this, that 90% of our members are vaccinated. And with the mandate, more nurses did choose to get vaccinated. So it's tiny, but it doesn't matter. It's like you lose one nurse at the bedside, you lose a nurse at the bedside, and other people have to step in and fill that nurse's shoes. And then it perpetuates that cycle of continuous overtime and nurse exhaustion and mental health stress and on and on and on.
Thank you very much, Ms. Pond. I was wondering if I could just have one more follow-up question, and that is unrelated. And you talk about nurses feeling despair. And I was wondering if you could pinpoint what that despair comes from. Is it from that lack of support you're talking about feeling helpless that they can't help all these patients, as Matt described, a whole ICU filled with patients with the same illness? If you could just kind of walk us through what that cause might be for that despair.
I'd be happy to try. So we are educated to provide nursing care to patients, and when we get that education, there's it's why we entered the nursing workforce, right? We became nurses to care for the whole patient, not just the illness, right? We want to help the whole patient, and that is not possible, and it hasn't been for a long time, and COVID exacerbated it. But we aren't patient-centered, and so that is what we have been educated to do, is to center our practice around the whole patient, the psychosocial component, the family components. Like communicating with family members is part of my nursing practice. And then when we are put in these environments where it is just fast and you don't have the resources, there's a nursing professor on the East Coast, identified that nurses face a different kind of trauma called insufficient resource trauma. That prevents us from providing that nursing care to the whole patient. And we see that in every day in what patients experience. And when you have a patient who's been in the ICU for a week and they don't have family coming, that patient's contact with nursing staff is very important, and we spend the most time with them. And when you aren't able to spend that time, and when you can see that there's confusion and you aren't able to help with the confusion with the patient, you aren't able to communicate with the family member, then it just, that is what gives us the moral injury. We know what needs to happen. We know the care. We've been educated to the care that these people need to get, and we are unable to do that. And you face every shift a moral dilemma, and then you suffer that injury, and that leads to that that despair.
And then I just want to add one more thing to what Matt said, just kind of an example. So OHSU had been putting out these infographics on social media of the number of patients who are hospitalized in the ICU on ventilators. And I think an example of despair is that you go on those posts and now that the numbers are going down, people are commenting, see, everything's fine. COVID wasn't real. The numbers weren't true. And as Matt said, no, the numbers were real. Those patients just died of COVID in the ICU because they were unvaccinated. That is why the numbers went down, not because COVID wasn't real, not for any other reason. They simply died and cannot be counted in the numbers anymore. And I think that's really important for people to realize.
And I would just like to add that one of the other issues that nurses on the ground are facing is that, like Matt and Natasha both spoke to, you have this moral dilemma of you've got a patient in a bed who is sick and dying of COVID. You've got another patient that doctors are getting a call to admit, and there's no beds to admit to. And so then the moral dilemma becomes, what do we do about this patient that needs to be admitted? Which one of these patients do we let die? And that, when you are faced with that kind of a decision day after day, which one of these patients do we let die? And then when that one patient that dies, that bed gets filled again immediately by somebody else who you know is probably going to die. You face that kind of trauma every single day that you come to work, and you know that your employer is just saying, oh, if you want to take a break, you've got to give your team over to, Matt, you give your team over to Natasha. Now Natasha's got all of that on top of everything. It's just compounding the work day after day after day, compounding the trauma. That's what the moral injury is that we speak of. That is what is driving nurses away from the profession that they chose and the profession that we love.
Thank you all.
Thank you very much.
Our next question comes from Ben from the Lund Report.
So I know you said you're waiting for more information about the nursing board's proposal as it relates to the mandate, but can you speak in general about just how you think it should look or the ways it would work best? Thanks.
Sure. I think that is a question that I would like to have Scott Palmer, our communications director, answer. Scott?
Good morning, everyone. Thanks, Ben. So, the Oregon State Board of Nursing is exploring this sort of rule change. Our understanding at the moment is that this is really more of kind of a house cleaning step with the governor's mandate. The governor has asked a variety of agencies who are responsible for licensure to kind of bring their regulations in line with that mandate. Certainly on the 13th of October, should OSBN consider any sort of alternative to that, or if those things change, we will obviously have a lot more to say about it. But at this point, we don't really know. It seems pretty reasonable to us that the governor's mandate would result in sort of some housekeeping and some clarification in various licensure agencies. So that's sort of what we're feeling about it right now. But clearly, if something were to change, we will absolutely have a position that we will share with you and all members of the press.
Thank you. And our next question comes from Lisa. Lisa, I'm sorry, I don't actually have your outlet, but go ahead, Lisa.
No problem. Yeah, thanks, Scott. It's Lisa Balick with COIN. Thank you. Question for Linda. Basically, when you look at all these things that you're looking for help with from the state, have you had any conversations yet with the governor's office in terms of asking for the dollars, asking for the scholarships, the nurse corps, the commission, those kinds of things?
Personally, I have not. I know that these are proposals that we're bringing, policies changes that we're bringing to you early on before we have actually, moved them on the ground to the governor. And like Scott said, just now, as we move things forward in the state of Oregon and start to move our proposals, we will definitely be keeping you guys all in the loop, and not, we're not going to do this blindly. We're going to do it very transparently and solicit as much support as we can from the communities in Oregon and the citizens that are impacted by the lack of workforce on the ground.
Thank you.
All right, we have just a couple of more questions. Lynne Terry from the Oregon Capitol Chronicle.
Oh, yeah. Hi. I thought you were going to email me. I caught me off guard there a little bit. So do you have an estimate of this minority of nurses who are likely to be fired because of the mandate? I just want to get a perspective on that.
It's like I said earlier, no, I don't have an exact number for you. It's what I said earlier. It's, we know that 90% to 96% of our nurses are vaccinated, and therefore that leaves a very small percentage of nurses that are unvaccinated, some of whom have medical and deeply held religious belief exemptions that are being honored by their hospitals, some of whom do not. So I truly do not have an answer of specific numbers.
Can I do a quick follow on that? Apparently, the Nurses Association is concerned that there are religious requests for religious exceptions, as they call it, being dismissed out of hand. Do you have any more information or perspective on that?
I'm going to turn that one over to Scott Palmer, our communications director.
Yeah, thanks, Lynn. Honestly, we've been talking about the issues around vaccination and mandates and mandate exceptions for a number of weeks. I'm going to kind of just point you back to our previous statements around it. We do have some concerns about whether or not all hospital systems are applying the exemption process equally or evenly. We certainly know that there are some concerns around Legacy's approach to those exemptions. We were going to direct you back to Legacy to ask them exactly how they approach those processes and systems. I think it's super important for us on this call to kind of remember, ONA has talked a lot about the vaccine mandate. We've talked a lot about exemptions. We've talked a lot about the impact on our workforce, and we're really here to call attention to what we need to do after the 18th of October to kind of really advance a conversation about the serious steps we need to take to address this historic staffing crisis. Happy to follow up with you offline if that is not a reasonable answer.
All right, and we have a question from Kristian from OPB.
Yeah, it's spelled out in the chat. It's just kind of, can ONA comment on the Kaiser Permanente possible strike? Are you supportive of the strike? What would the ONA like to see happen in this case?
Again, Scott, I'm going to call on you.
No problem. Yeah, thanks, Kristian. Anybody who's on the call here now who wants to talk to us a little bit more in detail about the potential of a Kaiser Permanente strike, we're happy to sort of do that offline. Obviously we support all of our healthcare and union colleagues in their struggles. I'm not going to sort of go into any specific details in this call, given that we're really focused on a series of other kind of bold and ambitious proposals, but I'm happy to follow up with anybody after this call if you just want to reach out.
And thank you. And our final question is from Elizabeth Hayes of the, I believe, actually, I don't have the outlet, sorry. Elizabeth.
Okay. Portland Business Journal. Yeah, mine relates to this buddy break system. I just want to make sure I understand that. So if a nurse goes on a break, they have to leave the patient in the care of another nurse. Is that it? And you don't want that to be the case, so that the patient, it sounds like, wouldn't have anybody looking after them, or maybe I'm misunderstanding. So I just wondered if you could clarify.
Yeah, that's a misunderstanding. What we don't want is that nurses have to double their patient load. So we do have hospitals in the state who have they have dedicated meal and break nurses. And that is the best practice. So right now what happens is, as Linda said, if I want to go on break, I turn to the nurse who's working near me and I say, hey, you watch all of my patients and I'm going to go on break. And so you doubled that patient assignment for the nurse. And then you go on break, come back, and you do the same thing. When you double a nurse's assignment, you double their workload, then things don't get done. So while I'm on break, there's things piling up waiting for me when I get back, right? Like medications that may need to be passed, contact with family members, reaching out to physicians, all sorts of things. And then I tell that person they can go on break and I watch their patients, and we just keep compounding it. It causes a lot of fatigue. The best practice is you have dedicated meal and break nurses. So you have somebody who comes in, they do not have a patient assignment. They come up and they say, it's time for your break. What do you need me to get done while you're gone? That helps reduce the fatigue, and it encourages nurses to take the breaks, because frankly, if I know that I have a lot more work waiting for me and I'm dumping a bunch of work on my colleague, I'm probably going to skip breaks. And that's what we see is nurses just don't take the full break. They grab some food, they eat at the nurse's station. You know, we patch it together, and it is not a functional system. So I'll just call out, like, and the nurse staffing law doesn't permit that. You must maintain staffing levels even during meals and breaks. And so OHSU, 1,000 nurses told the Oregon Health Authority that the meal and break system there doesn't work. The buddy system is not functional. And it doesn't maintain that number of nurses needed on the unit when somebody leaves to take a break. So 1,000 nurses reached out to the Oregon Health Authority and said, this is not functional, we need help. And then we do have other hospitals like Oregon Health, OHSU in Hillsborough, which used to be Tualatin. They have dedicated meal and break nurses. And then Sacred Heart Medical Center down in the Springfield, Eugene, they have dedicated meal and break nurses. And that is a simple fix to help with the fatigue. It is not a silver bullet for everything, but it really helps with that fatigue that you get shift to shift, to know that somebody is assuming your assignment and they are focused on just those patients. I hope that clarified. But no, we do not mean that the patients should be left alone. We just mean that we shouldn't be doubling a nurse's workload so that we can go eat on a 12-hour shift.
And I just want to add real quickly that what else you see, like Matt addressed, you know, with the dedicated meals and break nurse, is you see a reduction in fatigue, but you also see an increase in morale, because just that simple staffing of a meal and break nurse, but by the hospital saying, yes, we are willing to provide this, that says to the nurses that the hospital recognizes that there's value in nurses getting their meals and breaks, and they're going to take that extra little step to make that happen for them.
All right, that was our last question. I appreciate everybody's patience today as we had some technical difficulties. Everybody who's participated, all the media outlets will get a copy of a document with some of the key points and information so that you have it in writing. Those should be coming via email very shortly. If you did not have an ability to record this and did want a recorded copy of this press release or press conference, we will have one available to send out. So just email us and let us know that you want a copy of the recording, and we'll get that to you very shortly. And I appreciate all of your time. And if you have any other follow-up questions, please feel free to reach out to us or Scott Palmer, our communications director, and he will address any other questions you may have. Thank you.